All right, how you doing, sir? Well, doing all right? Okay. I'm gonna do an assessment before I do the manipulation technique. So lift your legs up for me. If you feel at home. All right. Scoot back for me just a tad bit. There we go. There you go. Thank you. All right. So we remember our down glide. Man, he has good down glides. I don't feel anything. I'm using my hands and my senses, so he may not be the best patient for this technique. He already has good down. Yeah, he has good down glides. Anybody else? Who'll try? Come on. All right, stationary arm along the cervical spine. I'll line my forearm up around C7, C6, and my stationary arm along the thoracic spine, cervical spine, fulcrum around C7, and then my stationary arm, movable arm is going to be midline of the occiput. All right, go ahead and move your right ear to your left shoulder for me. Your right ear to your right shoulder for me. Hold on 1 second. Let me focus. All right, right side bending. Write this down. 0 to 25 degrees. 0 to 25 degrees. All right, come back to central. Now I can't see the front if she's deviating or not. So y'all pay attention from the front for me. All right, move your left ear to your left shoulder. Zero to 40 degrees. Going side bending to the left. All right. Hold on. Anybody write that down for me? Write it down for me. So 0 to 25, side bending right. 0 to 40, side bending left. Write that down for me.
They writing it on the board.
That's the pre-treatment.
Yeah, that's the pre-treatment. All right.
It's good to acknowledge that in your documentation. Especially if you're doing something specific to this. It's good to show that.
All right. This is what I want. All right. Go ahead and rotate your head to the right for me. Zero to 50 degrees, rotation right. All right, go ahead and rotate to the left for me. And I get 0 to 50 degrees rotation to the left. So 0 to 50 rotation left and rotation right. Okay. Now, I'm gonna raise you up, okay? All right. Go ahead and look up towards the ceiling for me. Zero to 40 degrees of backwards bending, cervical spine. All right, go back to neutral. All right, go ahead and look down towards the floor for me. Forward bending, 0 to 20 degrees.
What was the backwards?
0 to 40. So that forward bending is limited. That gives me information. What kind of information does that give me? It can give me information about musculature and also facet joint movement. Okay, now, all right. Tabian, ruler out for me quickly. Come ruler out.
Of everything that they just gave you.
Could the lack of forward bending also be neurological if it were like an like keeping it
It could be.
I mean, closure increases the foramen sense, so it could be neurological.
But still, if there's a bulging disc, if she has a bulge in the disc, flexion can slightly increase the bulge depending on the direction of the bulge. That's a whole nother lesson right there.
And it also increases the tension through the
Yeah.
spinal, right? So you have one piece of the puzzle, your active range of motion. So now you've got whatever they told you subjectively, you've got your active range of motion. Now you look at this, and it's gonna dictate probably where you go next. You have other tools. So you're starting to develop some hypotheses.
That's why your foundational assessment is important, like looking at passive range, active range. The same thing we did in ortho, in your main muscle, selective special tests, and so on. That's why all that's foundational. That's very important. And like Dr. McClure said, pieces of the puzzle. Then you start building on and figuring things out. It's like detective work. This is what makes it fascinating being an outpatient orthopedic therapist. If you want to be a detective of the body, detective of movement. She's good to go. All right. I trust my teammate. He's a partner with me in the business. So I just run in late. He helped screen one of my patients for me. I'm running late. The patient waiting on me. I called him up. I said, screen this patient for me. I'm relying on him with his license. He did a good job for me. Thank you. Go ahead, lie down. I just made it in. My partner did the screening.
Right, so you know there's some restrictions there. What kind of things could be restricted at? Seth already talked about some neurological issues. What other things could be restricted? Muscle tightness, okay, what else? Okay, so joint restrictions. So you could have joint restriction, you could have soft tissue restriction, absolutely.
Yep. Ooh, man. A little bit more here. Considerable hypomobility of the down glide C7 on T1. Right C7 on T1, considerable hypomobility.
What number grade is that, guys? Grade 1 hypermobility, considerable.
Ooh, yeah. I'm gonna say left C7 on T1, considerable as well, considerable hypo. All right, I'm gonna go C6 on C7. How you feeling?
He said the same thing.
Mm-hmm.
I'm just trying to write it all out.
So now, Now, C6 on C7, down glides, both right and left. I'm gonna say considerable hypomobility. So what I'm doing now, I'm comparing her to other patients I've done this on. All right. To my typical, what I'm perceiving as my typical norm. So C5 on C6, down glides, both sides, considerable hypomobility. Woo. Now it got a little bit better here with with C4 on C5 on the right down glide. It got a little bit better. I'm gonna give her a slight hypo. And then on the left, considerable hypo. This C4 on C5, right? Working my way up. Ooh. Right, C4, no, C3 on C4. On the right, I'm gonna say slight hypo. On the left, considerable. Woo! See, this right here is not good. This is not good, you all. Cause I'm gonna look at her up glides too. So what I'm showing y'all have learned this as treatment, and is assessment and treatment. Now, I'm up at C2 on C3 and I'm gonna halt there. Slight on the right, C2 on C3 down glide on the right, I'm gonna say slight. And then on the left, I'm gonna say slight. She got a little bit more compared to her lower. Let's see. No, I take that back. I'm gonna go considerable, sorry. C2 on C3 considerable on both sides. I changed my mind based on what I felt. Okay, now, whoo, that wore me out. Dr. McClure, you do her up glides for me. Well, she made me work with that. Man, no, Jessica, I don't see what Dr. McClure feel with her up glides on both sides. Good, Gracie, I'm gonna see if she worked Dr. McClure much as she worked me. You gotta be in shape as a PT. I've never felt a neck like that. Man. You good right there, Dr. McClure? I had up a little bit higher.
Yeah, I think we're good right here. Actually, no, go down, can you go down to where like maybe 1 inch? I'll tell you when. Right there. Okay. Okay, right there, Jess. Now, I'm gonna tell you, I feel like Jessica's having a hard time relaxing me.
Yes.
You know, I'm gonna do it for a second.
I felt that too.
I'm gonna let her get the ease. I'm gonna let her get the feel for me. I'm gonna get the feel for her. So what am I doing right now? Suboccipital release, right? I'm gonna just relax her muscles, let her get the feel for me. My hands, okay? So I may do this for a couple minutes in the clinic. I may come here and just, all right, and then go back at it. Okay, just relax. And it could be some of what I perceived as guarding initially.
Isn't she super stiff?
Super still. I felt the same thing, Dr. McClure, like she's having a tough time relaxing.
Yeah. Hey, open your eyes for me, Jessica. You okay?
Mm-hmm.
So I had a little insider intel that told me that she may have had some nystagmus at CSM with some things too. So I'm being observant. You do feel anything funny, you let us know.
Mm-hmm.
Okay. So that was my precursory screen. Now I'm going to go back. So I like to go top down. I feel like I locate C2 a little easier. So I'm going to look C2 on the right. compare that. I'm gonna go ahead and go down and compare. I feel like she's a little bit more restricted, C3, C4 versus C2, C3. This is C4, C5, that's a little better. C5, C6. You okay?
Mm-hmm.
Sure?
Mm-hmm.
Okay, so C7, T1, C6, C7, C5, C6, C4, C5, C3, C4, C2, C3. So she felt more restricted to me in the upper mid-cervical spine. So probably C2, C3, C3, C4 on the right, up glide, felt more restricted to me than the levels below them, okay? So I'm comparing multiple things, side to side, left and right, that level compared to the levels above and below, and to my previous knowledge of patients that I've felt, right? I'm making comparisons of all of the above. Okay, so now I'm gonna compare the other side. Before I maybe give her a final grade, but that's kind of what I'm thinking in my mind, right? I'm thinking she feels, compared to patients I've felt before and what I felt on that right side, that's what I felt. So, here's the opposite. Okay, so I started up top. I'll go back and classify it, but I'm just kind of getting the feel. So here, I feel like she's moving better in the upper mid-cervical spine on the left. Okay, so left, C2, C3, C3, C4, I would call her maybe a slight hypomobility compared to a considerable hypomobility on the right at C2, C3, C3, C4. Okay, you guys with me? Okay, as I work my way down, and I'm here C4, C5, C5, C6, okay? Considerable hypomobility, C5, C6, maybe even a little bit more so. C7, so I would say from C4, C5, C6, C7, C7, T1, I would call those on the left considerable hypomobility of upglide on the left compared to the right, compared to the levels above it. So that is where I felt the most restriction. Okay, so upper mid-cervical on the right, upglide, and lower mid-cervical on the left, upglide.
So circle those. That's important, right? Put a circle around those.
And then the courtesy rub down, right? Stretch.
So now we know her side leaning to the right was wet. Scroll back down. 0 to 25. So we know, okay, we know she has to be able to down glide on the right, but we know she has to be able to up glide on the left. So we confirm, so we've got more information now. So what could be, based on what Dr. McClure reported, she had a large segment restricted up glide on the left. That could be a problem that we need to address. That could likely help with side bending right, and it can likely help with forward bending as well. Okay, so now I can, with the thrust manipulation technique, I can make that work to target the lower cervical for the up glide. They can come back and target the opposite side more near the upper for the up glide, because Dr. McClure felt more restriction on the right with the up glide towards the upper cervical spine, right? So I'm making it match up. So now, all right, let's do our high thrust high velocity, low amplitude thrust to target improving the up glide at C5, C6, C7 area. All right. So what I'm going to do, unlike some of our counterparts, and just manipulate her without doing a ligamentous lock and a facet joint lock. Okay. So this is what I'm going to do. All right. Just relax for me. I'm going to do a ligamentous lock. Good. To the segment. So I'm going to flex her to the segment of where I know I have C6 engaged, at least C6 engaged in flexion, right? Okay. So now what I want to do is get her into a side bent position. So I'm going to side bend her. Let's see. Yeah. So I'm going to side bend her to the left and do a facet lock. Okay. I'm going to side bend her to the left to do a facet lock. So I did a ligamentous lock down to the segment with forward bending down to the segment, a ligamentous nuke lock. I'm locking it out. Okay. Then I did a facet lock. She's kind of wincing, so I did a facet lock by side bending her to the left. All right, now I'm gonna introduce rotation to the right at that segment. I'm gonna kind of put my hand right here too. Rotation, you may wanna come around this way and look. Did a rotation right. Just relax for me. What are you having for dinner today? What are you thinking about? What are you thinking about for dinner today?
I don't know. I haven't think about it.
Okay. There we go. Got it. All right. There you go. Just relax. Okay. That targeted those segments. Okay. And just relax for me. All right. So I know I was on those segments. So I flexed her forward bend, side bend to the left. And why did I rotate her to the right? What did I want the right side to do? When I rotated her to the right and took her to the thrust manipulation to the right, what did I want the left facet joints to do at C6? Yes, C6 on C7, I wanted to up glide. So that's why I rotated her to the left. And then boom, I added a rotated to the right. You see? So now I gotta address the opposite side, but now with the opposite side, I'm forward bending to the segment of C3 on C4 because Dr. McClure felt the restrictions in that area. So I'm not just doing this I'm not just going in blinded doing this. So most of the time when you go to chiropractor, they get you side bended, lock out the mid-cervical spine, then they boom. And when they do that and they don't do a ligamentous lock to the level, they really just doing a OA manipulation. They're doing an OA, high velocity, low amplitude thrust, because they just taking you side bending, rotating you, boom. And so it's not specific to a specific level. So now,
don't let the side bending component here throw you either. That is
Yeah.
simply to lock it out. Because I can
Yes.
assume you're like, well, that's a down glide. So don't let that mess with your mind. It is just to lock out to the level. Your flex
Yes.
is to lock out to the level. Your side bending is to lock out to the level. The motion that he's doing, y'all follow that?
The
That's why it's
motion-
the up glide.
the
right?
motion's
Even
at
though
that
you
level.
down glided to that point, that's just to lock out to that level.
thank
okay?
you, Dr. McClure, for pointing that out.
Make
Thank
sure
you.
we're all good on that.
Yes.
Because that can get confusing. It confused me.
Mm-hmm. So now we got to get an up glide of C3 on C4 on the right, right? So now come here. Notice my flexion is going to be much less because it doesn't take as much to get to that segment. Put my hand right there. So now I'm going to side bend to the right, right? And I kind of got my index finger on C3. my index finger, because I'm gonna use that to help facilitate. So I got my ligaments locked with flexing to that level. I'm side bent to that level to lock it out. And now I rotate. She say, what she gonna have for dinner? Huh? There we go, got it. All right, that was just to distract her, you know, get her thinking about something else. And she was thinking about what she was gonna have for dinner, you know. And then you felt we got an audible release there. Now, that was without any soft tissue work. That typically I do soft tissue work before I do this type of work, okay? So now, all right. So we treated some problem areas with the thrust technique. So go ahead and sit up.
Hey guys, what do you know about cavitation too? What effect does it have on the soft tissue? You didn't do any soft tissue work, but what does that cavitation have? What effects is that gonna have on the soft tissue? You guys know?
Where's that going? Okay. Problem with side bending right. So I'm not gonna look at all of those again. I'm gonna look at side bending right and forward bending. Okay, look straight ahead from me. This is letting me know if she's up gliding better. All right, go ahead, move your right ear to your right shoulder as far as you can. Whoa. Midline. 0 to 45 degrees on the right. All right. Here's the going. This is why you take objective measurements. I've gone to some physical therapists, they don't take objective measurements anymore in the clinics now. They don't. They just go straight to, I don't know what it is. I don't know. All right, go ahead. I'm just gonna do side bend to the left. Go ahead, side bend to the left for me. Midline of the occiput. That's about 0 to 42 degrees. All right. Now, forward bending, right? All right. Fulcrum of external mediatus. My movable arm is just beneath her nose, like parallel to nose. I have to visualize this. And my stationary arm is perpendicular to her, I guess, temporalis or temple. All right, go ahead and look down for me as far as you can. Whoa. All right. So, 10, 20, 0 to 30 degrees. Okay, now, let's see something, just for the information.
What grade of thrust manipulation did he do? 5, right?
Yeah.
What kind of effects does 5 manipulation have? Mechanical?
Go ahead, rotate to the right from as far as you can. Zero to 65 degrees. Right rotation. All right. All right, go ahead, rotate to the left from as far as you can. 0 to 60 degrees to the left. Okay. So that was after that thrust manipulation, targeting the areas of restriction. So doing a ligamentous lock to the specific areas. A ligamentous lock, facet joint lock. So that way when we introduce the technique, we locked out everything else and it's specifically mobilizing those areas. Everybody get that? Okay. So let's see. All right. Now, this is someone who had significant amount of restrictions with that. All right. Now come up, Tavian. We've already cleared Tavian, right? So let's see. Come up, Tavian. I'm just gonna look at Tavian. I didn't notice we didn't have any. I didn't assess his up glides, but let's see. Yeah, just sit down right there. That's good, Tavian. We do know Tavian had upper trapezius tightness though.
So nobody had an answer for me about the cavitation on soft tissue. What kind of effects do you think it might have? Anybody have any thoughts? Okay. So arthrokinetically,
Side bend to the right a little
when
bit.
you get that cavitation, there's also some endorphin release. Okay.
Side bend to right, 0 to 40.
When endorphins release, what happens?
All right, go
You
back.
feel good, right? You know people that are like knuckle poppers?
Side bend to the left for me.
As a therapist, I think we get some endorphins released too when we get that pop, right? There's a little bit of feel good on
Side bend left, 0 40.
But it also has an effect on the soft tissue. You're gonna get reflexive muscle inhibition.
Yes.
So if you have soft tissue tightness and you get that cavitation, you're gonna get reflexive inhibition of those muscles. So if you've got somebody who's got tight muscles, they get a positive effect, okay, on that. But let's think about the person who's hypermobile and lax, and you're just going in there and you're not being specific to a certain level. You gotta be cognizant and aware that what are you gonna get? You're gonna get muscle relaxation of muscles that are probably necessary in working hard to stabilize an area. So you have to be wise in who you choose to do this with, okay? They need their muscles. Some people really need their muscles to stabilize some areas there.
Good. Rotation right, 0 to 70 degrees. Now we about to experiment, right? Typically your patients who have greater impairments typically get the most results, like the better outcome, because they have more to gain. Does that make sense? So I could take an athlete who is, say you got a moderately strong athlete and a considerably strong athlete, and I take a minimally strong athlete, which one can I likely get more gains with? The one that is minimally strong, right? So I get more gains with that person. All right, rotate to the left of me as far as you can. Good gracious. That's all. That's 72, 0 to 72 degrees. So, how about this? All right, that's all I'm gonna look at with him. And we'll come back. Go ahead, lie down. And we'll just come back and look at side bending. We'll see if he benefits. Specifically, we'll look at post measurements for side bending. Oh, you've been good since that day? Yeah. I had a patient when I worked at Baptist. He worked for the Hyundai plant, and he just came complaining for me. So with him, I'm just gonna go mid cervical. I'm gonna go. Got it. I didn't even have to do a high velocity thrust technique. All right, we'll come to the other side. See, sometimes just getting it set up, you can get it. Next. There we go. All right. All right, go ahead, sit up for me. How you feeling? Good. So you really don't have to be scared to do this. If you clear your patient, and most are timid with doing it, but it takes practice. But if you get your patient set up. This is the setup. And Dr. McClure and I realized this with courses we go to. Most of the time, the most challenging part is the setup. When you're learning new techniques, it's all about the setup. Once you get the setup down and you get the person to where you want them to go, then it's just being confident and providing the thrust. You see, that's where most students might feel, oh man, I don't want to do that. I don't even want to attempt to try that, you know, because of the timidness. But if you get the setup, you good. You're not gonna hurt the person. You know, our structures are stronger than what we think. Okay, what did I say? I'm gonna look at side bending again.
Yes.
Now this is on the slide, but y'all can, all right, go ahead and move your right ear towards your right shoulder for me as far as you can. Good Lord. Man. Oh, I stay midline. 0 to 55. All right. 0 to 55, side bending right. Man, that's why you gotta look at, you gotta do the numbers. Don't be lazy, y'all, in the clinic. Take time to use your gonies. Because your patients, like, the patients only know, sometimes patients only know if they're improving when you take the objective measurements and you let them know, this is where you were when you started, this is where you are now. They internalize the numbers, you know. Go ahead and side bend to the left. So I'm just lining this up how it's supposed to be aligned. So to the left now, and it's just the numbers, he's 0 to 35 degrees. 0 to 35 to the left. So it's less. Fascinating. What happened? The right took some of his range of motion to the left, didn't it? Man. Hey, sometimes they can't. You can see that. You don't know how the numbers gonna come out. That's why you have to take measurements. But overall, how do you feel? All right. So yeah. Do y'all want to play around with the setup with your patients with that as Dr. McClure and I walk around?
Just the setup.
Yeah, the setup. Yeah. All right.
But not that.
Hey, do you guys understand how to tell that you're getting motions at that level? Because I don't know that we've done really like PIVMs or anything with them, but like, do you understand how to feel? Like we say flex to that level. How do you know you flex to that level?
What's it called? Not compression, it's called approximation. Question mark?
You're gonna feel, what are you gonna feel? If you're flexing, right? We got the spine here,
No more movement.
right? And I'm gonna flex. Okay, and I wanna flex them, your C2, C3, C4, C5. Let's say I wanna do the C5, C6. I can put if I wanna flex through C4, C5, okay? So what I can do, right, is I can put my finger here, my middle finger at that level between the spinous processes, right? And now I'm gonna flex. What am I gonna feel? Approximation or opening? Opening, right? So you're gonna flex them till you feel opening at that level, but not the next level, right? So you're just gonna flex till you feel that start to open. Okay. Now what about when we side bend? What are we feeling? Approximation. Okay. At that level, right? So that's what Dr. Carter said. He had his finger, his long finger there, right? I like to palpate with my middle finger. So here, going to that level. So you feel the approximation. Now you know you're at that level. Transition into the position you want to be in. Do what you're gonna do.
Okay.
Okay?
I was thinking that the thrust was at a specific cervical spine level. Is it just the C6 that you're moving on the
So
C6?
it is at a specific spine level.
Okay.
So the level that we working down to, creating a ligamentous lock and a facet lock, that's the segment.
Okay.
And if Tabian should have felt my index finger on that segment as well as Jessica, because I got my index finger in on that segment when I felt when I got to the segment. And then, like Dr. McClure said, I felt the spacing when I got to the segment, and then I biased. So when I know I'm at that segment, so I biased my fingers to my index finger to move C6 on C7 to
Okay.
move it anteriorly with the rotation,
So you're
like
moving,
this.
the body, not just the transverse processes, question mark. That making sense?
So the transverse processes and the arch. Pedicle, I'm kind of capturing it all. So say I come down, get my facet lock, right?
Yeah.
I'm gonna say C6. Let's see, this T1, C6 on C7. So I'm coming here, and I got get that flex right there, and got them side bent, and I'm capturing this, and I rotate.